You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 21st, 2025. We are doing our orientation series, and today's topic is atopic dermatitis. This is presented by Dr. Aarti Pandya. She's an associate professor of pediatrics and is the medical director of the Food Allergy Center at Children's Mercy Hospital in Kansas City, Missouri.
Morning from Kansas City, and welcome to the COLA orientation series. My name is Dr. Aarti Pandya. I am one of the staff allergists and immunologists here at Children's Mercy. I'm the medical director of the Food Allergy Center. Today we will be starting COLA by talking about the clinical management of atopic dermatitis. Relevant disclosures for today: I'm a speaker for Sanofi Regeneron. I have a grant with Thermo Fisher for food allergy, and I am a writer for the practice parameter revision for immunotherapy. All right. So, and then let me make sure. Sorry. Okay. Yeah. All right. Today's learning objectives are going to be to discuss the pathogenesis of atopic dermatitis, the diagnosis of atopic dermatitis, the role of allergy testing, as well as the appropriate treatment for atopic dermatitis. This is definitely one of my favorite topics to talk about, as the fellows at Children's Mercy can attest to. Let's start first with what is the definition as well as the epidemiology of atopic dermatitis. This is defined as a chronic relapsing inflammatory disease with a strong association with atopic conditions as well as an atopic etiology. Particularly asthma and food allergy are strongly associated as atopic conditions, although we know that rhinitis as well as allergic rhinitis is associated with atopic dermatitis. The lifetime prevalence in the United States of atopic dermatitis in school children has been reported up to 18%. The data on prevalence of atopic dermatitis, of course, in adults is much more limited. The vast majority of cases, atopic dermatitis will have an onset before the age of 5 years of age. Of course, it can have onset beyond that, but the vast majority is going to occur in that timeline. Genetics is certainly a complicated topic with atopic dermatitis, but this graphic shows kind of the role of genetics that plays into atopic dermatitis. And when we look at this image, the genes that are kind of more close to this diagnosis are more closely associated, and you can see that closer association versus further association, or like the strength of the relationship with atopic dermatitis dependent on how close it is to that diagnosis. We know that filaggrin is one of the ones we think of most commonly, but all of these different genes have some role in atopic dermatitis as well. With regards to filaggrin gene, so patients with filaggrin gene mutations, particularly if homozygous or compound heterozygous, have early onset severe and persistent atopic dermatitis. Additionally, with filaggrin mutations, you can have a variety of these different changes to your epithelial skin barrier, which results in the development as well as the progression of atopic dermatitis. So here we have disruption of keratinocyte differentiation, as well as corneocyte integrity and cohesion, impaired tight junction formation, decreased water retention, altered lipid formation, as well as enhanced susceptibility to cutaneous infection. So all of these play a role, again, in the development of atopic dermatitis, as well as our perpetual presence of the actual disease itself. Talking first about our epithelial barrier dysfunction. So the dysfunction primarily resides in the stratum corneum. Here we have a depiction of the stratum corneum, the stratum granulosum as well. Here we're going to have reduced filaggrin production, as we discussed with the mutation in the previous slide. This results in an imbalance between stratum corneum protease and antiprotease activity. You can also have tight junction abnormalities, as demonstrated in this image, altered composition, and lamellar organization of epidermal lipids, microbial colonization, the itch scratch cycle perpetuation, as well as release of pro-inflammatory cytokines. So here we have a disrupted stratum corneum barrier as a result of the disease. And then we have introduction of a variety of things here, including irritants, pollutants, microbes, allergens, all of which we know are known triggers for the actual disease. This can certainly go on then beyond our epithelial barrier and result in a dysfunctional immune response, where we have recruitment of Th2 cells, Th2 cytokines as a result. We have mast cells that get recruited as well. We see TSLP represented here. TSLP is a known epithelial cytokine, which can result, again, in perpetuation of the cycle of this particular disease. So this shows the importance of, in general, our epidermal barrier to protect against all of these things. And when there's a disruption in the barrier, how ultimately any one of these triggers can cause, further issues from any of these, and then lead to, of course, disease progression. Immune regulatory abnormalities are multiple in atopic dermatitis. So these are some, it doesn't include all of them, but here we have increased synthesis of IgE. So we saw from the previous slide here, we have, increased Th2 skewing, which results in Th2 cytokines being secreted. So from that, we have increased synthesis of IgE that can occur. From that, of course, we can have increased levels of IgE to multiple allergens, and this can include aeroallergens, that can include foods. We can have microorganisms as well as enterotoxins as well. Additionally, we have increased expression of CD23 on B cells as well as monocytes. We have increased surface expression of Fc epsilon R1 on antigen-presenting cells in the skin. We have increased levels of this chemokine called CTAC, or T-cell attracting chemokine, as well as TARC, also known as thymosin activation regulatory chemokine. There's increased secretion of, as I mentioned, the cytokines that come from Th2 cells, decreased secretion of interferon gamma from Th1 cells, decreased CD4, CD25 T regulatory cells, decreased secretion of antimicrobial peptides by keratinocytes, and then increased levels of these for various things here. So monocyte cyclic adenosine monophosphate, phosphodiesterase with increased IL-10 and prostaglandin E2. And then we have increased number of type 2 innate lymphoid cells. So all of these immune regulatory abnormalities occur in atopic dermatitis, as well as lead to the pathogenesis of the disease. Here we have another pictorial representation of many of these immune regulatory abnormalities that are going to occur. Again, we start with the skin barrier being disrupted. Here we have dermal dendritic cells. Here we have our Th2 cells, as well as Th17, Th22. We have the role of the lymph node that is represented here. And then essentially we have this continued cycle that goes on from all of these, things, including itch scratch. We have lichenification. All of these are pictorially represented here with the myriad of cytokines that we see, chemokines that we see. So pathogenesis here is complex for sure, but we know that these processes are occurring. We have increased in IL-31, which leads to increase of itching. We have intensification of cytokine effects that is occurring as well. We have T-cell activation, largely with, Th2 cells, but additionally that can cause recruitment, activation, chemotaxis. And then this also pictorially at the bottom here represents your non-lesional skin in the beginning here, in the middle stage here, your acute stage, and then the changes that occur in the chronic stage. Excellent image from Middleton's that kind of represents all of these changes, as well as the variety of different cells and cytokines that get activated in those stages. Okay, so what about associated atopy with atopic dermatitis? So atopic dermatitis has genetic predisposition to develop an IgE response to common environmental allergens. And then early onset atopic dermatitis is also associated with an increased risk of food allergy, asthma, and allergic rhinoconjunctivitis. However, food sensitization is also 6 times more likely in atopic dermatitis. Individuals with atopic dermatitis are 6 times more likely to have egg allergy. Atopic dermatitis is 11 times more likely to have peanut allergy. And in moderate to severe atopic dermatitis, you have 40% of individuals who have confirmed food allergy by clinical history or oral food challenge. So it's important to know because this has implications on if you perform food testing with a clinical history and without a clinical history, what you are going to pick up. It also has a strong, you get a strong idea here of associated atopic diseases. And maybe this also gets you some idea of pre-introduction testing for peanut allergy and why we have that in the United States. So all of these things to think about. When we have atopic dermatitis and when we have a presentation of atopic dermatitis, it's also important to have a differential for this particular disease. And again, here I want to take a second to use that term eczema and contrast it with atopic dermatitis. Remember, eczema is a description of a rash. It's not the same thing as atopic dermatitis. You have eczematous changes that occur in atopic dermatitis. So if this is occurring, there's a lot of etiologies here we need to take into consideration. Netherton syndrome, especially if you have multiple IgE-mediated food allergies, as well as ichthyosis, changes of the skin is something you want to think about. Chronic dermatoses is also something, of course, for us to think about. Contact dermatitis has a strong overlap with atopic dermatitis, so it's certainly something we want to think about, especially in our refractory patients. Infections and infestations, if you have a lot of involvement, especially in your intertriginous regions or in between your digits of your fingers, scabies is, of course, something to think about. There is, of course, HIV-associated dermatitis. For cutaneous T-cell lymphoma, if you have a presentation that looks, sounds, seems like atopic dermatitis, but is occurring in the later stages of life, this is certainly an etiology that you want to strongly think about and keep in the back of your mind, as this can present as late onset atopic dermatitis. Immunodeficiencies, as you can see, some of these here do have a presentation with atopic dermatitis or strong presentation of eczematous skin lesions, but then you would also have other associated findings in these disorders. Metabolic disorders. So some of these, could be just zinc deficiencies. Some of these could occur as a result of gut-losing enteropathies. All of these things are certainly what we want to think about, but metabolic disorders can result in having pretty significant eczematous skin findings, and then proliferative disorders is also something we think about. All of this to say is, with thinking about atopic dermatitis, and when you have a patient that comes in with a clinical presentation consistent with this, make sure we're taking a good history and kind of keeping all of these etiologies in the back of our head. All right. So what are the features of atopic dermatitis? Are there standard diagnostic criteria? There are not standard diagnostic criteria for atopic dermatitis. And the way that we make the diagnosis of atopic dermatitis is largely based on clinical features. So this is very important for us to know the major as well as the minor features of this particular disease. Again, because this is a clinical diagnosis that we are going to make. So the major features here are going to include, of course, pruritus, facial and extensor involvement in infants and children, flexural lichenification in older children as well as adults, as well as chronic or relapsing dermatitis, and then a strong personal or family history of atopic disease. Some of the minor features are also listed here, which can include xerosis, cutaneous infections, nonspecific dermatitis, ichthyosis, palmar hyperlinearity, KP, pityriasis alba, nipple eczema, white dermatographism, and delayed Blanche response. I have a second slide on this coming up. Anterior subscapular cataracts, elevated IgE levels, or positive immediate type of allergy skin tests. So all of these features we are going to think about in somebody who's presenting with eczematous skin, and you are seeing if they meet clinical features consistent with atopic dermatitis. So, talking further a little bit about some of these terms, lichenification is when your skin has become thickened, kind of a leathery texture. Prurigo refers to spots that are intensely pruritic. There has been some significant scratching and irritation to the area, and it causes kind of these damaged areas. So you can see these prurigo nodules in this second image here. And sorry, the first image here is showing lichenification, that thickness that has occurred as a result on the skin. Ichthyosis is kind of this rough, scaly skin that can occur, especially in some of the later stages of atopic dermatitis. Okay, so going back again to that terminology I was referring to, eczema versus atopic dermatitis. Remember that eczema is a description of a skin rash. It is not a diagnosis. So this term refers to pruritic xerotic patches or plaques of the skin that can occur. They can be erythematous, they can be flesh colored, they can be lighter colored as well. So that, again, it's a description of a rash. And atopic dermatitis is a medical diagnosis that is associated with atopy or has some of those other major or minor features that were on the previous slide. Again, different rashes can be eczematous in nature. So we have a slide here depicting this, where we have atopic dermatitis with that classic flexural distribution in this particular image. Dyshydrotic eczema is also known as kind of a skin washing irritation that can occur, and you can see here on the palmar surface of the hand some lesions that can occur. Contact dermatitis, again, also has eczematous skin lesions. We have neurodermatitis here, more so on the elbow region. Nomular dermatitis, more circumferential or circular lesions that, again, are eczematous in nature. Seborrheic dermatitis, here we can see patches on the hairline, again, that can appear eczematous in nature, or stasis dermatitis, which is going to occur in areas where edema is occurring. In terms of the history of atopic dermatitis with common distribution, we can see the different areas that are affected based on age in terms of the distribution pattern. So in younger infants here, we can see lots of extremity involvement, whole extremity involvement, lots of truncal involvement, and then facial involvement as well. And then we can see in older individuals, lots of flexural involvement here, right? So antecubital fossas, popliteal fossas, neck area that's involved. We see the hands involved in this area as well as the feet involved as well. Atopic march. So this is a concept where essentially we start with the development of atopic dermatitis, and then subsequently we develop associated atopic conditions in one particular individual. So what is kind of the timing of onset of all of those? So we see that eczema or atopic dermatitis, see how I made that mistake here too. Atopic dermatitis kind of has peak involvement in terms of our age. And then we have a food allergy with the peak involvement occurring a little bit later here. And then asthma peak involvement even a little bit later here, and then rhinitis peak involvement occurs even a little bit later, but we can kind of see a log curve here more so with that particular disease. So different atopic diseases within the atopic march are going to have a different peak onset depending on the individual condition that we are talking about. All right, clinical variants of atopic dermatitis. So there's multiple here to talk through. Ocular abnormalities certainly can occur in atopic dermatitis. This includes allergic conjunctivitis, atopic keratoconjunctivitis, eyelid dermatitis, blepharitis, keratoconus. Notably, especially when we talk about atopic keratoconjunctivitis, these can be sight-threatening diseases. So we want to be particularly I don't want to say aggressive, but particularly, very involved in the management of this particular disease when it comes to ocular occurrence. And I'll kind of talk about some clinical tips and tricks that we can utilize for that. But again, we want to be very, very careful in these individuals, especially if we are having this manifestation. We're going to want to ensure that we have co-management with ophthalmology that is occurring. Hand dermatitis, especially because of chronic irritation from hand washing or just utilization of our hands. That's a known clinical variant that can occur. Infections. Remember that we have a baseline disrupted skin barrier, as I showed in some earlier slides. So we have a propensity to develop these infections in individuals with atopic dermatitis. Eczema herpeticum is a complication of a viral infection, HSV. This can be a life-threatening disease that occurs, so we want to ensure that this we can promptly recognize, as well as management occurs pretty promptly in those individuals, as this has a high rate of morbidity mortality. Molluscum contagiosum also occurs more frequently in individuals who have atopic dermatitis as well as HPV. Eczema vaccinatum is a consequence of vaccination that can occur in these individuals. We see it more rarely now, largely from the smallpox vaccination, where you can develop disseminated disease, actually. And then we have Staphylococcus aureus. So we know that that particular microorganism or bacteria is a high likelihood to occur in individuals with atopic dermatitis. Again, we want to ensure that we're promptly recognizing and treating that particular disease to prevent the sequela of that, including bacteremia, sepsis, etc. And then Malassezia is a fungi that has increased development in individuals that have atopic dermatitis. Going back to that concept of contact dermatitis, so this disease is known to occur more frequently in individuals who have atopic dermatitis, both with the irritant contact dermatitis as well as allergic contact dermatitis features of or variants of contact dermatitis. So again, in somebody who is refractory and having maybe some atypical features like more vesicular features, more in a distribution pattern that looks like a contact allergen or irritant is affecting them, we really want to think about that particular abnormality. What are some of the triggers? Apologize for this kind of running in the banner here, but so what are the triggers for atopic dermatitis? So excessive bathing without subsequent moisturization. Make sure you take that in full. It doesn't mean just excessive bathing alone is going to cause the atopic dermatitis to be refractory, not treated. It's without subsequent moisturization that can occur. Low humidity environments can certainly trigger it. Emotional stress, cirrhosis can trigger atopic dermatitis as well. Overheating and sweating, use of hard water, exposure to solvents, detergents, aeroallergens, and then lastly here, what's listed is contact irritants and allergens. All right. Let's get into my favorite topic. I truly mean that this is one of my favorite topics because there's a lot of misinformation out there about this, and there is kind of this golden opportunity that we have as allergists when you have a patient with atopic dermatitis that is suboptimally treated to meet this need right off the bat, and get these patients treated, recognize appropriate food allergy in these patients. Lots of things that we can do as allergists right off the bat. So what am I talking here? What issue am I bringing up here? When you have a patient who has atopic dermatitis, and this is recognized in our literature, suboptimal treatment for this disease can cause a high degree of frustration from the parent end and the patient end. So what ends up happening in these individuals? They end up thinking there must be something I am doing, or there must be something that I am encountering that is leading to the refractory nature of my disease or constant fluctuations of my disease. So let me see if I can just take care of that and then get rid of this disease, which is so hard to deal with because of the pruritus that occurs with it. I don't like the way that these these eczematous skin lesions look. Let me just see if I can get rid of it by a one shot. And so we end up in the hands of somebody who doesn't know the data behind food sensitization in atopic dermatitis. We have a food panel that gets performed, and now we have potentially multiple foods that have sensitization on that panel. Now we start avoiding those foods, and now we are at risk of loss of tolerance of those foods. And now we potentially have developed IgE-mediated food allergy as a result of that. So this is a common occurrence that all of us as allergists have certainly encountered at any of those stages. So what the bottom line is that atopic dermatitis treatment is an unmet need, and we really want to make sure that we are trying our best to aggressively manage these patients, lead to as much clear skin as we can, target patient satisfaction as best as we can, because this is going to help prevent that entire sequela that I just mentioned earlier. It's a little bit of a shift in thinking as well from, previously how we used to think about atopic dermatitis. Previously, we used to just think, well, just educate the patient that flares are going to occur and then just have them deal with that. But the reality is that doesn't work on the end of somebody who has atopic dermatitis. So let's go through these individual points. With suboptimal treatment, there's an increased risk of morbidity, as I mentioned, as well as lack of satisfaction. When seeking additional evaluation, there's a misperception that food avoidance will lead to improvement in atopic dermatitis. Atopic dermatitis patients are more likely to get IgE food panels. With unnecessary avoidance of food, atopic dermatitis have increased loss of tolerance, knowing that your patient already has a higher propensity of food allergy, where potentially eating and tolerating that food regularly in the diet could have prevented that. So avoidance of food allergens is therefore strongly associated with promoting the development of IgE-mediated food allergy. And this potential dilemma is something that we need to recognize occurs in atopic dermatitis patients, and we have this opportunity to help out these patients much carefully from the beginning. Let's talk further about the harm of food allergy panels. So food IgE testing performed in the absence of clinical history can lead to harmful outcomes even in somebody who doesn't have atopic dermatitis. Here's the overall US pediatric population, here's the overall food sensitized population, and here's the actual food allergic population. And this graphic doesn't even take into account how atopic dermatitis patients are 6 times more likely to be food sensitized. So you can see that occurs in those individuals. We have undue costs with specialist referral, additional testing, oral food challenge, putting undue costs onto the health system, and then of course all of the consequences including loss of tolerance to a food, psychosocial concerns, nutritional deficiencies, increased costs related to dietary modifications. May seem like an easy solution to do, but this is something we want to avoid in these patients. And then here are the specific harms of food IgE panels outlined by their actual harms. Physical harm, psychological harm, financial cost harm, opportunity cost harm, health disparity, or healthcare disparity costs. For those who are on live right now, my second talk is actually on food allergy, so we're going to dive a little bit deeper into this topic in that talk as well. And I will, even for those who are watching after this talk has been given, please pair this as best as you can with the food allergy lecture, because I will go into some of this more in detail in that lecture. Okay, all of that is true, Dr. Pandya, but I know that the literature has previously talked about dietary elimination. So are we just going to ignore that concept? What's going on with that, and where should we go with that? Great question. Let's talk a little bit about the updated data that has come from this. So there was a systematic review and meta-analyses identifying 10 randomized control trials, around 599, about 600 patients, addressing benefits and harms of dietary elimination for atopic dermatitis. So compared with no dietary elimination, low certainty evidence revealed that dietary elimination may slightly improve atopic dermatitis severity. And you can see that here. Pruritus as well, and then sleeplessness. However, subsequently, Bayesian sensitivity analyses revealed that most individuals pursuing dietary elimination strategy would experience little to no benefit. So these studies went into our JTF panel on our most recent atopic dermatitis kind of grade paper that came out. And the grade paper suggested against elimination diets compared with an unrestricted diet. So that is the official recommendation that has come out. And so in our practice, we do not do dietary elimination in atopic dermatitis. And so that's certainly something to think about. If you have questions about that, I'm happy to address those at the end. I feel pretty strongly about this personally. Again, that's my personal belief as an allergist, but certainly there is room for some discussion here, but this is what has come out from the most recent data. All right, what about the natural history of atopic dermatitis? So the natural history here is that atopic dermatitis follows a chronic relapsing course over months to years. Patients with mild disease may experience intermittent flares with spontaneous remission. Patients with moderate or severe may rarely clear their disease without treatment. And most children with early onset atopic dermatitis are clear by late childhood, but the disease persists into adolescence and adulthood in variable proportion of cases. All this to say, these are, variations that can occur within atopic dermatitis where many can grow out of the disease, essentially. That's one of the things that your patients and parents are wanting to know. But if it doesn't, you want to assure them that, well, we have great treatment for atopic dermatitis. So, how should I approach these patients? Again, we do not have diagnostic criteria for this particular disease. But let's say you have a patient who presents with eczematous and pruritic dermatitis. Do they meet criteria for atopic or our diagnostic criteria? Again, there's no strict diagnostic criteria, but those major and minor features that I listed earlier, that's kind of what exists there. So if they don't, you want to think of alternate etiologies here. If they do meet it, the question here is the disease severe or not? If it's not severe, here's what we plan, or here's what we plan to do. And then again, we monitor the success of the treatment. If it's severe, again, we want to consider all of these things. All right. Another important topic for us to be cognizant about is atopic dermatitis presents differently in diverse skin tones. So this is a clinical consideration and a health disparity that we have to evaluate. So in 2002, a race-based analysis of U.S. National Ambulatory Medical Services showed patients identified as Asian Pacific Islanders accounted for 16% of 8 million visits of atopic dermatitis. The groups of non-white race faced worse outcomes and inequities related to access to care. Children with atopic dermatitis in the United States identifying as Black or Hispanic are more likely to miss school and use primary care and the emergency department for treatment for atopic dermatitis as opposed to seeking specialist care. And so I'm not saying that these two kind of specialties are not good at managing atopic dermatitis, but perhaps the need to advance to go to advanced therapies would get missed if you only see these types of physicians as opposed to seeing a specialist for atopic dermatitis. These are two great websites that actually show presentations of atopic dermatitis, eczematous skin lesions in different skin tones. And so I highly recommend, especially for our first years, checking out these websites, getting a good idea of how the presentation looks differently in different skin tones. So we're not, missing that particular disease. All right, here is the large graphic and excellent, concise kind of, not algorithm, but like how we approach treatment in atopic dermatitis from that JTF paper. So this came out in 2023. I love this chart so much. I highly recommend in your practice, if you have the ability to print this and put this somewhere, it's so great for having a concise area where all of our treatments for atopic dermatitis are laid out. Let's start from the beginning here. Here, clinicians managing of atopic dermatitis should address diagnosis, education, triggers, adherence, and moisturizers. So, of course, that's a very important thing here. This joint guideline is made from all of these different practitioners here. Here's some further information from a website that we can access those parameters. All right, let's talk about the individual interventions. And I do want to note that I am going to go into the detail of all of these interventions a little bit later. Topical treatments. So here we have topical treatments listed by the various different types of treatment here. And then you can also see the recommendations for the treatment is going to be different based on mild, moderate, or severe disease. An example for this is bleach baths. For instance, bleach baths, my goodness, try saying that 5 times straight. So for moderate to severe atopic dermatitis, there is a recommendation for adding dilute bleach baths, but in mild disease, against using dilute bleach baths. So take into consideration, the severity of the disease as well as the individual consideration. So in terms of I'm only going to highlight on a few here because then I'm going to go into all of these in details. Prescription moisturizers. For mild, moderate, and severe, there's a conditional recommendation against using it. And then, also here, the strength of recommendation is listed as well as the certainty of the evidence in terms of low, high, very low, etc. And then the other thing I'm going to mention here is topical corticosteroids. There's a strong recommendation in terms of age 3 months and above in favor of using it with a high certainty of evidence regarding mild, moderate, and severe disease. So we're going to come back to all of these individual treatments throughout the talk here today. Okay. Now, let's presume you've diagnosed a patient with atopic dermatitis. How do I track the severity of the disease over time? This is a great tool that we can utilize called the EASY, or Eczema Area Severity Index score, which looks at these 4 parameters: erythema, edema papulation, excoriation, and lichenification, and then takes into account the involvement of the body surface area of all of these regions: head and neck, upper extremity, trunk, lower extremity. We use all of those to subsequently calculate a score, and then we track that score over time. Here's kind of the way that we calculate it. Also, there are online calculators where you can just input this and then subsequently get out a score. But regardless of how you calculate it, I do think there's some utility here in tracking EASY scores over time. One thing for the sake of time that I haven't included in here, there's also another scoring system, there's 2 other scoring systems called the SCORAD and Investigator Global Assessment, or also known as IGA. So those are 2 additional scoring systems that can be utilized. So please talk to your university that you're training at and get an idea of what your university is utilizing for tracking atopic dermatitis severity. I actually did have a slide on this. So Investigator Global Assessment, so this is a 5-point system based on the morphologic description, and then you just give a score based on that. Again, it uses we're using this to assess the severity of atopic dermatitis. All right, I won't spend too much time on emollients, but these are the different types of emollients that we can utilize. And there's a variety of different types of emollients that are on the market. In terms of what I recommend, because I'm not going to mention specific brands in this talk, but what I will say is there are a couple things we have to take into consideration with emollients. One is the type here, but the second is what the label says about the emollient. So there's 2 types of labels with regards to fragrances that are out there: unscented and then fragrance free. You want to make sure that that you're counseling patients on utilizing the label that says fragrance free, because unscented actually has a scent and then a masking agent. So the patient is still being exposed to the fragrance basically within the emollient. The other labels that you want to make sure that your patients are looking for are dye-free and paraben-free. Those are also known irritants in atopic dermatitis. So let's go through those labels again: fragrance-free, dye-free, paraben-free. You want to ensure that those 3 are present on whatever emollient you're using. And then in terms of the type of emollient, we have options of lotion, cream, ointment, gel, and balm. The consistency is going to vary, of course, with gel and ointment and balm having a more thicker or viscous consistency. And then where we ideally use these. The point is here that any of these can be utilized depending on the nature of the baseline skin, whether it's more oily or dry. You may have better results with one versus the other. Also, one more personal tip that I have is to check in with your patient about how they feel about their emollient, because sometimes children in particular are not they don't love the way that the ointment or gel feels on their skin, and that can lead to decreased compliance with your emollient regimen. So check in with your family or patient, see how they feel about it, and then alter that based on how they feel about it. And again, to ensure good compliance with the therapy, because there is a good role of emollient here for patients with atopic dermatitis. All right, so we looked at the recommendations regarding who needs bleach baths. Again, this is moderate to severe atopic dermatitis patients. So this helps reduce bacterial colonization on the skin, especially with Staphylococcus aureus. The way that we perform it is adding about half a cup of bleach to a tub full of water, bathing in about 5 minutes, and then once removed, rubbing a moisturizer on the skin within 3 minutes of getting out of the bath. We can repeat that about twice a week. We want to make sure we're avoiding the mouth-eye region when individuals are doing bleach baths. And again, we have data showing that moderate to severe atopic dermatitis patients are going to benefit from this measure, whereas mild atopic dermatitis patients, there's a recommendation not to use bleach baths. Okay, so here's a pictorial representation of safety tips. Follow doctor's instructions, avoid getting in eyes and nose, don't submerge the head, don't use undiluted bleach, and then don't ingest the bath water. All right, wet wrap therapy. If I can just actually go back here a couple slides and make sure I mention, make sure I mention the grade recommendation for wet wraps here. So, and then I will kind of talk about the actual, the way that wet wraps are performed. Let me just get oriented here really quick. Application frequency, maintenance. I apologize also here if it's not on here. Okay, it doesn't look like, unless I might be missing it here. So let me just go on to talking about the nature of wet wrap therapy. So my point with this is that there is data to show that this works. However, there are some side effects or adverse effects you want to watch out for with wet wrap. So what is conceptually a wet wrap therapy? So it's where we have a patient who has, let's say, taken a bath or wettened their skin, and then you moisten a dressing under warm water until it's slightly damp. Now, before putting this occlusive onto the skin, there are a couple of options of what can go under wet wrap therapy. Those options are emollient or a mild topical steroid. We should not be using moderate to, we'll see kind of a chart here which shows the topical steroid potency chart. So we really shouldn't be using anything beyond the lowest potency, like a 6 or a 7, maybe 5 at most. That's really the most that we want to put under the occlusive barrier. So that's one option, or of course just emollient. We don't want to use your topical calcineurin inhibitors or anything else like that under wet wraps. Then you put the wrap with the moist dressing around the affected area, and then you put a dry wrap over it. And then you want to be careful putting on, of course, clothing over this, not to disrupt that. We leave this on for several hours or overnight if possible. Let's see if I don't have a subsequent slide on this. So we want to make sure that this is not resulting in, causing issues with disruption of temperature of the skin. That's one thing that can happen. This can also further disrupt the skin barrier just depending on how it's utilized, how many times it's utilized. So we want to be a little bit careful in who you recommend this for, but in individuals with particularly dry skin, this could be a great way to help kind of re-moisturize the skin for those individuals. All right, so that's talking about emollients as well as bleach baths as well as wet wrap therapy. So we are going to now hit on treatment of atopic dermatitis per our most recent practice parameters. And one thing I want to talk about before going into all of the data regarding all of the individual treatments is the two phases in which treatment should be utilized for atopic dermatitis. So the first phase is treating uncontrolled disease or active disease, also referred as treating flares of the disease. The second is intermittent therapy, or also known as maintenance of remission therapy. This is to prevent future flares with proactive therapy. So this JTF panel and paper recommends using proactive therapy to areas that frequently flare with topical calcineurin inhibitor or mid-potency topical steroid over applying topical treatments only in reactions to flares. So there's a strong recommendation for this with moderate certainty of evidence. The moral of the story is think about how you can get your patient into clear skin, and then think about once they're in a clear skin area, how you're going to prevent flares to those particular areas. This is such an important concept that is going to result in having more days of clear skin, better patient satisfaction, reduced morbidity in atopic dermatitis. I emphasize this with my fellows so much when I teach with patients who have atopic dermatitis, and I cannot emphasize this point enough to individuals who are just watching this lecture for the first time. This is such an important measure that we can take. Okay, so here we have an image here depicting concept of induction of remission and then treatment of subclinical inflammation in atopic dermatitis. That's really, the reason that we do this. And so we have induction of remission that can occur and then subclinical inflammation that can occur. But with maintenance therapy, that subclinical inflammation can remain at bay. Whereas with reactive treatment, you're just kind of chasing your tail as best as you can. And that doesn't necessarily lead to better outcomes in these individuals. So, and potentially, let's say your patient says, well, Dr. Pandya, I really don't want to use that medication as much. And so I'm not really into this concept of, using treatment proactively. But look at how often you're ending up using treatment in a reactive fashion compared to doing it in an induction fashion and then maintenance of remission, or maintenance of clear skin is a better way we can put it. So again, I think I've mentioned this point a lot of times. You can tell how passionately I feel about this by the amount of time I've spent talking about this, but such an important measure, such a simple one too, that we can take as clinicians that can just lead to better patient outcomes. All right. Now moving on to topical corticosteroids. So topical corticosteroids are going to vary based on potency. They're going to be low potency or ultra low potency, medium potency, high potency, ultra high potency. I have a graphic on this that's going to come up. The side effects for this can include greater likelihood with long-term use of having issues with striae, skin atrophy, telangiectasias, acne, skin fragility, and bruising. We know that children are also at greater risk of HbA suppression. That doesn't mean you don't use topical corticosteroids. It just means that you use them in the right way with the right consideration of potency. So let's look at that a little bit further here. Okay, so these are select topical corticosteroid preparation, and then here are the groups, and this is all showing kind of the potency of the topical steroid. So your lower potency is going to be 5, 6, 7 here. Your medium potency is going to be really the 4 range. The medium to high is going to be the 3 range, high is going to be 2, and then ultra high is going to be the number 1 or group 1. Oh, so takeaway point from this, couple of takeaway points. In terms of which potency we utilize for atopic dermatitis, really we're targeting around 3 or 4 at the highest amount. That's not to say that 1 and 2 should not or cannot be utilized in atopic dermatitis, but if you are having to do this, then consideration of advanced therapies is certainly something we should think about. And our general recommendation from our papers is to utilize topical steroids that fall in the 3 and 4 potency range. Of course, the side effects, a lot of the side effects that I mentioned in the previous slide, do come more with the higher potency of the topical corticosteroid. All right, what about the efficacy of topical corticosteroids in atopic dermatitis? There was a network meta-analysis of 219 randomized trials with nearly 32,000 patients evaluating 62 topical interventions for the treatment of atopic dermatitis and high-potency topical steroids were ranked among the best treatments of improving atopic dermatitis. Mid to high topical steroids and topical tacrolimus were among the best treatments to improve itch severity, and then mid-potency were deemed to be the most effective for long-term control of atopic dermatitis. So again, I'm going to circle back to topical calcineurin inhibitors here, but again, this paper is just going to show you the efficacy of topical corticosteroids within patients who have atopic dermatitis. All right, what about topical calcineurin inhibitors? Probably my second favorite topic within atopic dermatitis to talk about, or third favorite. Maybe my favorite is food. The second favorite is using treatment in an induction of remission and maintenance fashion, and then utilizing topical topical calcineurin inhibitors would be my third favorite. So there's two topical calcineurin inhibitors here for atopic dermatitis, tacrolimus and pimecrolimus. This is generally for moderate to severe for tacrolimus, and then pimecrolimus, mild to moderate. And then in terms of the strength of the topical calcineurin inhibitors, so 0.03 percent is for, I'm sorry, this should actually say for ages 2 and above, 2 to 18, and then for adults, 0.1% is for adults. So again, I apologize for this typo. It should be greater than 2 years of age is what this medication is advertised for. I will touch a little bit on off-label use of topical calcineurin inhibitors here. And then pimecrolimus, 1% is approved for ages greater than 2. Here we have no risk of skin atrophy or acne. There is transient application site burning and stinging. It's very common. And so the way that I kind of get around this with patients, there's two ways you can think about. One is to put the medication actually in the refrigerator and give it from the refrigerator, although it can be colder, of course. The second is mixing it with an emollient, and that can help reduce a lot of that burning application, because what can happen is if that happens with the first, second, or third application, parents or patients may not want to use it any further after that, but that effect is known to decrease over time, so potentially using it to prevent this side effect from the beginning right off the bat could be beneficial. There's also a black box warning for malignancy. However, studies have not demonstrated evidence for a causal link between cancer and then topical calcineurin inhibitors. And again, we know that this works at the nucleus level when we think about the individual cell. Okay. Topical calcineurin inhibitors have a high degree of efficacy in atopic dermatitis over placebo as well as mild doses of topical steroids. The JTF panel paper, one of the recommendations that came a little bit later in the table is to use it once a day. And then lastly, off-label use can and should be considered in infants 3 months of age and above. Safety has been established to this. And then pimecrolimus efficacy across atopic dermatitis is intermediate between topical steroid 5 and 6, 7 in terms of potency. Tacrolimus is similar to topical calcineurin inhibitors in the 0.03 version. 0.1 version, it's similar to potency level of 4 for topical corticosteroids. Combination use may lead to slightly larger benefits, and then few studies compared the effects of TCIs by location of the body, albeit that those did not suggest similar treatment effects across body parts areas. Okay, I will try and be concise because I know that we are running close to time here. So topical PDE4 inhibitors, so crisaborole is an ointment that's approved for the use of atopic dermatitis in children and adults 3 months of age and above. Prominent side effect of this is burning of the skin. We want to mix this with an emollient or refrigerate it again to help prevent sequelae or consequences of the burning. Severity of atopic dermatitis suggests that we use this for mild atopic dermatitis and use it to treat mild flares as well. So it's less certain and likely that benefits occur in more severe atopic dermatitis. Patients who highly value non-topical or non-corticosteroid treatments certainly can have benefit of using this. And then 5 randomized controlled trials of 2,000 participants address that this particular medication resulted in atopic dermatitis remission, reduction in itch, and then the reduction in chance of flares as well. Highly consider this for your patients, particularly your pediatric patients. Topical tapinarof is an aryl hydrocarbon receptor agonist approved at age 2 and above. 2 randomized control trials looking at 1% once daily application with patients receiving the vehicle achieved a primary endpoint of an IgA improvement at 8 weeks. So this was in these trials, one trial had 407 participants, one had 406 participants, and then these were the improvements versus placebo that occurred. Side effects include folliculitis, headache, and pharyngitis. Topical JAK inhibitors, so there's ruxolitinib and then deglocitinib. So the topical ones show here the data with ruxolitinib having 2 8-week randomized phase 3 trials with identical design. Basically, bottom line is there was an improvement in IgA as well as EZ. There can be pruritus and burning of with the application of this on the application site, as well as URIs and then headaches. And then with delgocitinib, there's a 4-week randomized trial with 137 patients aged 2 to 15 years of age with improvement in EZ score. Dupilumab is approved for the use of atopic dermatitis in patients 6 months of age and above. It works by blocking IL-4 receptor alpha, which subsequently blocks these 2 cytokines or interleukins. And this has revolutionized the treatment of atopic dermatitis. This is a subcutaneous injections. Older patients have loading dose followed by maintenance dosing. Pediatric patients may not need a loading dose. Adverse effects include facial redness, seronegative arthritis, and enthesitis, psoriasis, and then psoriform dermatitis as well. The dupilumab efficacy, I have a couple of slides on this, but there's a pretty clear improvement here that you have significant improvement over placebo in terms of improvement of EZ score, and this is reported in 6 months of age to 5 years of age, and I have a subsequent slide showing the same improvement in 6 years of age up to 11 years of age, again in the EZ7 improvement severity greater than 75% improvement, and then the same effect we see in the adolescent population, and then the same effect seen in the adult population. Again, I'm kind of going through these a little bit more efficiently for the sake of time. Bottom line, dupilumab is an excellent therapy, has revolutionized the treatment of atopic dermatitis, and we can see that it is very effective. Now here is, this is from the grade paper here that shows kind of the use of all of the topical therapies for atopic dermatitis listed out here, as well as the data for those. Oral JAK kinase inhibitors, so there's abrocitinib and upadacitinib. Both of these are approved at 12 years of age and above. There are risk of infections, cardiovascular events, cancer, thrombosis, and death. In terms of those who have undergone those treatments, you can see in the Measure Up 1 and Measure 2 trial, there was a significant improvement in patients who achieved a response compared to those who were on placebo therapy. So you can see that with the dosing in both of these trials here. I am actually going to move through this slide for the sake of time. I apologize about that. And then in terms of abrocitinib here, the recommended dose of this is 100 milligrams, and then you can increase it. We did see a higher effect in this particular trial with use of a higher dosage, but we also saw an effect that occurred with the lower dosage. Bottom line, we improved outcomes in atopic dermatitis with these medications. And then tralokinumab is approved for adults with moderate to severe atopic dermatitis, works just on blocking IL-13. Dosing list here is listed below. I think I have, I don't have an efficacy chart on this, but it has shown to improve EZ score as well as those basically achieving clear skin in individuals who have atopic dermatitis, another tool in our toolkit box for treatment of atopic dermatitis. Allergen immunotherapy has been a topic that has kind of been, I don't want to say controversial, but has mixed recommendations over time. And in the previous parameter, it didn't have clear recommendations necessarily with regards to use of this. But in this practice parameter of atopic dermatitis, there is recommended usage of allergen immunotherapy that is supported based on a couple of trials here for patients who have moderate to severe atopic dermatitis. So again, making sure we look at that severity. UVB light therapy also has good data here on utilization for moderate to severe atopic dermatitis. So this is another tool in the toolkit, especially if you own a machine that can do narrowband UVB light therapy. Again, this is whole body treatment that we're looking at. Systemic immunosuppression, there's data that still supports adding cyclosporin. There's no longer data supporting using MMF, azathioprine, or methotrexate. Systemic steroids do not have a role in acute or chronic atopic dermatitis. Again, I recommend heavily referring to this chart for that. All right. Summary: atopic dermatitis is a chronic inflammatory disease. Pathogenesis involves largely a disrupted epithelial barrier, strong association with other atopic dermatitis. Treatment has expanded. It's vast. Treatment can be done to induce remission and maintenance. Ask yourself, what is the goal in your treatment of atopic dermatitis? What is their goal? Are they satisfied? What not? Why not? And what else can we do?